The title of this paper is Clinical Outcomes of Conduction System Pacing versus Right Ventricular Septal Pacing in Atrioventricular Block, the CSPACE randomized controlled clinical trial. And we're going to hear about this trial from the lead author of the paper, Dr. Chow. Dr. Chow is in the Department of Medicine at the University of Melbourne in Australia. So right now it's nighttime there, and I have the privilege of interviewing him. And I want to start off by asking Dr. Chow to tell us a little bit about the clinical trial that he, multi-center clinical trial that he pulled off in Southeast Asia. Dr. Chow, it's a pleasure to have you here.
Thank you. Thank you very much for having me. Yeah, we're very excited to share this trial. It is a landmark RCT that compares conduction system pacing to right ventricular septal pacing in patients with AV block. And we looked at 4 distinct outcomes, endpoints, and they are pacing-induced cardiomyopathy, need for CRT upgrade, heart failure hospitalization, and all-cause mortality. And it is the first trial that demonstrates superiority of conduction system pacing in this group of patients by reducing the incidence of pacing-induced cardiomyopathy and the need for CRT upgrade. I can go into a little.
Yeah, I want to hear a little bit about enrollment, what kind of ejection fraction these patients had, and any endpoints you can share with us about cardiac function, heart failure, hospitalization, all-cause mortality, which I know you also kept track of, as well as for those listening who are implanters in terms of how well the conduction system leads did.
Yes, so we randomized 202 patients in a one-to-one fashion to each arm, conduction system pacing and right ventricular septal pacing. And we looked at pacing-induced cardiomyopathy and how many events per 100-person years in each arm. And so the composite endpoint was a lot lower in conduction system pacing at 7 events versus 20 events in the RV pacing group, primarily driven by a lower incidence of pacing-induced cardiomyopathy of about 5 events in the conduction system pacing group versus 15 events per 100-person years. And in terms of CRT upgrade, no patients in the conduction system pacing group required a CRT upgrade in their follow-up, whereas about 2 events per 100-person years in the RV group ended up requiring a CRT upgrade in their follow-up. In terms of heart failure hospitalization, the event rate was higher in the RV pacing group at 3 events per 100-person years, but it didn't reach statistical significance at 0.056. Mainly because the study was never powered to look for differences in heart failure hospitalization. But we do see and report the event rates there. And in terms of mortality, there is no difference in mortality in the 2 groups. The study cohort are simply patients who need a pacing solution for AV block. And they can't be patients who require CRT upfront. So patients with left bundle branch block with an ejection fraction of less than 35, they are automatically disqualified because in these patients, a physician would have put in a CRT upfront, a biventricular device upfront. But for all other patients who do not meet the standard CRT eligibility, they are eligible for recruitment. And so the average ejection fraction for our patient cohort was 60.9%, patients with no heart failure to begin with.
Can I ask you a question? How did you define pacing-induced cardiomyopathy?
Our paper defined pacing-induced cardiomyopathy by a drop in ejection fraction by more than 10%, resulting in a final ejection fraction of less than 50. So for example, if they dropped from 65 to 55, they do not count as pacing-induced cardiomyopathy in our paper. They need to result in an EF of less than 50 to be, in our perspective, clinically significant PICM. And the drop needs to be more than 10%.
Now, you had several patients in the conduction system group who did have a drop in EF. Did you go back and look to see if they were conduction system capture or LV septal capture?
We did actually, yes. We did look at that and try to figure out whether were the pacing-induced cardiomyopathy in the CSP cohort specifically, were they primarily because it was just LV septal pacing, or whether we actually engaged the conduction system. And I have to say the results are somewhat mixed bag. So there were patients who clearly we had engaged the left bundle who still developed an ejection fraction drop of 10%. It was one of the limitations of the trial. So remember, a drop of EF of 10%, it's not specific to pacing induced, because in the era of coronavirus, COVID-19, myocardial infarct, they can all drop ejection fraction by 10%. So this definition of pacing induced cardiomyopathy is by no means perfect. But we do recognize that, you know, in our cohort, a high proportion of patients have very high pacing burden. And yeah, regardless of there was no trend to say patients with RVsP tended to have a higher risk of PICM versus patients with left bundle branch pacing.
And the time course of the follow-up for your study is 25 plus or minus 12 months. So it's not like we're following patients for 5 or 10 years, which is the life of a modern pulse generator. Was there the timing of the pacing-induced cardiomyopathy, did it increase over the time of follow-up, or did it only occur early on?
Yeah, so we saw pacing-induced cardiomyopathy anywhere between 3 and 24 months. So they weren't particularly centered in the first half of the follow-up period or the last half in particular. They were somewhat spread throughout. And we recognize that in a lot of cases, the more follow-up period we do, the higher the chances of picking up any deterioration in ejection fraction. Which is why we decided to report the events per 100 person years, recognizing that the time of follow-up does affect the incidence of these events.
Now, I have a question for you about lead revision. It occurred more often in the conduction system pacing patients. Can you tell us a little bit about why what the lead revisions were for, please?
Yes, absolutely. So the lead revisions for all patients will be detailed in the supplementary material and provided as a supplement. But they were largely for chronically rising thresholds, and they could occur anytime between 3 to 6 months to 24, 48 months. And there was a mixed bag of LV septal pacing with chronically rising threshold, and also his bundle pacing with chronically rising threshold. And we didn't particularly see that one technique had a higher risk of rising threshold versus LV septal pacing. But we only had 9 patients who required lead revision, so perhaps that's the limitation of that cohort.
So I have a question for you. What do you think are the 3 take-home messages, 2 or 3 take-home messages for all the cardiologists who are practicing cardiologists? What do you think we should leave them with? The important messages. This is an important study. So
yeah, so the first take-home message is the fact that this study demonstrated superiority of conduction system pacing over RV septal pacing in general patients who require AV block, in that it reduced the incidence of pacing-induced cardiomyopathy. That's important because it supports the use of conduction system pacing as an upfront pacing technique for someone who has AV block. I think that is the key message to take away, and that CSP should be attempted to see clinical superiority over conventional RV septal pacing.
I think, please, everyone who's listening to this podcast, put in the perspective that this was a prospective randomized study, multiple centers in Australia, New Zealand area, and they looked at patients who had a high pacing burden and essentially normal EFs. And they found in a short period of time, the drop in EF was substantially higher with RV apical pacing compared to left bundle branch block area or conduction system pacing. The take-home message is you put a generator in someone for 12 years, you're gonna see much more of this. So I think it's an important lesson, important take-home message. Final question. So having done this, what's your next project? What's your next area of interest? The next question you think needs to be answered in this field?
Yes, so I think perhaps the more studied question was the role of conduction system pacing in CRT, the availability of solid randomized controlled trial is still sought after, and so I think that's still important to study, and also longer term outcomes of these patients, because we only have a follow-up of 24 months plus minus 11th. And so as we follow them up longer, we will be able to see a fuller picture about the overall event rates of these outcomes, especially with heart failure hospitalization, meeting only 0.056 p-value. We might be able to understand a fuller picture with longer term studies.
Well, thank you very much, Dr. Chow, and your co-investigators. I'm sure everyone's going to be looking forward to reading the full paper in JACC, Journal of the American College of Cardiology, and the supplemental tables and figures, which will be online with publication of your paper. I could not agree more with your final recommendations about where the field is. That's the left versus left clinical trial, which we're doing here in the United States and Canada, looking at people with EFs below 50% and conduction system pacing to CRT. So we'll really look forward to reading your paper in detail. Thank you.
Thank you very much.